I'm going to speak. Good morning. Sorry, I didn't even compliment you. So, good morning to everybody. I'm going to speak. I was not here in the first talks, but I'm going to speak. So, this is the one. I'm going to speak about the role of fluorescein and geography in ROP. Well, you don't need fluorescein and geography. Of course, you don't. But it's when you use it, it's very compelling and help you a lot. But the diagnosis and all the decisions that you make in ROP are with indirect ophthalmoscope. Even if you have a red cam just to take images, the decision is always under indirect ophthalmoscope. But you can, okay, I'm still breathing because I was running from one place to the other. So you can do the angiography under intravenous injection. That's what I most used, but you also can use it with oral fluorescein. I never had any kind of local or systemic complications, but you should always have medication prepared for anaphylactic shock. Never used it, but if you don't have it, you may for sure have some kind of problem. So that's how I use, always have epinephrine, adrenaline, not prepared, but near the place where I'm going to do the angiography. The diagnosis, as I told you, is with indirect ophthalmoscope. So that's the image, of course, with 3D that you have. But when you add the fluorescein, you have a lot of details that only with fluorescein you can have. So you can see really in not only the posterior pole, but in the periphery, how it is the ROP. You can see the stage and localize precisely the stage, the severity of the lesion, of the ROP. As you can see here, you have much more severity. Of course, you can say that with this image, but with angiography, it adds much more to your sight. And then you go home and you study all the images you had during that day, and you can learn such much amount of things in physiopathology and make a more conscientious decision in that baby. Also in follow-up, it's very important because you can have sometimes hemovitreous after a long time, and you have to know if there is some kind of activity in that ROP that justifies that hemovitreous, or just following up the fibrosis to know if it is only fibrosis or if you have some kind of activity in that fibrosis. As you can see here, there is just a little staining, so this fibrosis is completely inactive. Sometimes you have surprises because this baby was lasered, and years after the laser you can see occult neovasels. So you always have some kind of surprises when you do this kind of exam. We began to use most angiography after the anti-VEGF injection because we began to find some interesting findings after the anti-VEGF injection. You could have this kind of pinpoint from choroid to retina. So you can have this kind of pinpoint feeling in the choroid. We still don't know absolutely what this means. You can have what most of us know, some funny things in some funny findings in the vascularization of the retina. So you can have these shunts. You can have this anomalous dichotomous branching. So somehow the retina is not vascularizing the way it should vascularize. So in the early times of angiography, you can see that there is a lot of abnormality in the capillary bed. Here you can see the scalloped retina, and you have vein to vein, not arterial to vein shunting. You have sometimes vein to vein shunting. So there is a lot of strange vascularization of these very young retinas. You have more, this is a more aggressive kind of vascularization. And sometimes you have these basin-like vessels that go like stretching to the periphery. And guess, sometimes you can find this in spontaneous regressed ROP. So as we began to study those kids, we found that these findings were common to the babies that were injected with anti-VEGF and the babies that had, some of the babies, the most tiny one, that also was not injected but had a spontaneous regressed ROP. So these are common findings between those two kind of progression of retina. So what I think is that those findings are not connected to the anti-VEGF used, but with the disease itself that has some hurt in a very, very young, not vascularized retina. Now, in the posterior pole, Subhadra also told that, and perhaps Shengu, in the posterior pole you can also have some findings, a pinpoint that you still don't know what this means. So you have like in the intermediate phases of the angiography, you have pinpoints in the retina. Somehow the retina or the choroid are not functioning so well. And the retina, the vessels are encroaching the retina. That means you don't have a normal vascular zone as you have in the other, in the normal retina. And we have the persistent avascular retina that I understood you were speaking about it right before I get inside. And the avascular retina, you can have normal vascular retinas, so it's almost 2, sometimes 3 diameters to the oris aorta of a vascular retina. But if you have more than that, then yes, you have a persistent avascular retina. And that's quite a finding, not a problem and a finding, because you don't know. There is several theories if the peripheral vascular retina is ischemic or it's not functioning. So it's 2 different things. If it has photoreceptors that function, it needs oxygen, so it's ischemic. If it does not have peripheral photoreceptors functioning, it does not need that oxygen. And we still don't know the answers. We just have indirect proofs that there is some kind of activity or not in this peripheral retina. So when we have those peripheral vascular retinas, we must look for the transition. Sometimes you have a normal, no kind of leaking anything in that transition, so it's an inactive, in my way of saying it, peripheral vascular area. And other times you have some kind of activity, some kind just of staining, and sometimes some kind of really exudation. So it's different kind of severity of this transition. So we must always look up to those transitions. And you don't release just on laser. Why? You can go and make all the laser of these peripheral vascular areas, but years later, if you make the angiography, you can still, in some cases, not in all cases, but in some cases, you can still have the occult neovessels and some kind of exudation, not just staining of the fibrosis. So even doing laser of this peripheral vascular area, you must not be completely quiet and sure that nothing is going to happen in that eye. So you should follow up always those eyes, even with laser. So I think Ihab will speak about this. Yes, Ihab, you are going to speak about the peripheral vascular areas. So I'm not going to speak long, but I think we all want to have some kind of biomarkers to know if those peripheral vascular areas are going to make some kind of problem or not for a long time. But Ihab will say that, we'll speak about that. I think so. Now, the recurrence diagnosis is clinical. You don't need to have angiography to make the diagnosis of recurrence. But of course, recurrence is easier to understand and to evaluate the extension if you have angiography. So here you have a kind of recurrence that you can see all the ischemic posterior retina, and not only the impregnation, but also the diffusion of contrast. So you have activity, neovascular activity there, and this is kind of a pattern, advanced pattern recurrence. And you, of course, I used to do laser, but sometimes you can just do a second injection depending on the area where the recurrence is. What I mean is, if it is still in the posterior zone 2, I used to make a second injection. If it is in zone 2, I make laser of the periphery. Now, you have a second a recurrence pattern that is at the advancing edge here and at the first site of ROP. Of course, you can somehow detail this just with the images, but if you make the angiography, you can be sure what kind of recurrence pattern you have. Now, angiography also helps you in making the decision or understanding the different diagnoses from ROP. We have a lot of a typical ROP nowadays, what you call ropers, like this baby that it has some kind of aggressive ROP or oxygen-induced ROP, and it helps you in the differential diagnose if you make fluorescein angiography. This is perhaps a preterm fever, because you can have some kind of this ANSA, peripheral ANSA, and this activity in the optic disc, so can help you distinguishing between the fever or the roper, because there is also a connection or some kind of continuous between fever, roper, and ROP. And this case is a case of incontinentia pigmenti. It seems like ROP, but no, it's incontinentia pigmenti. And we also did laser. And it's more difficult to have in the premature baby the Coats disease, because it was not a premature baby. But it's also in the differential diagnosis of ROP, the Coats disease. Now, angiography is a field where IA is very easy to stitch on, because it's very easy to have this data, to feed the IA with this data, because it's very objective data. So there is a lot of IA management for the images of angiography. So from angiography, what I think it's important, it's a safe procedure. At least in my hands, I never had any kind of problem with angiography, fluorescein angiography. It helps for you to understand the physiopathology of ROP, improves the visualization, of course, and increase the sensitivity to detect the ROP stage. It's a good tool for the decision. It's not fundamental, because the decision is clinical, but it's very good tool to help you in the decision and to study this persistent avascular retina. Well, of course, we can live without fluorescein angiography, but it would not be the same. So if you can somehow have fluorescein angiography, you can be very lucky to use it. You don't have just those very expensive machines. You have also nowadays Indian and Chinese very good machines that are very not so expensive and can help you in your way through ROP. Now, I was also asked, and this is more expensive, to speak about OCT in ROP. I don't have experience, so it's not like in angiography that I do have that experience. But OCT also helps you understanding all that's happening in ROP. So you know that when the fovea is developing, the photoreceptors, the ganglion cells and the nerve fibrils come from inside the retina and open this pit that we know as a pit. So it opens. Somehow, when you have a premature baby, this stops. So the eye of a premature baby is different from the eye of a normal baby. Usually, like a sign of really prematurity, you can have the inner layers of the retina on the over the fovea. So the fovea is much more thick than the normal fovea. So that's a hallmark of the preterm infant fovea development. So you have a normal out layers, but a very thick in layer that didn't come outside from the fovea. So that's a hallmark, and you can find it in the adults that were premature. So it's a hallmark sign of prematurity. The other thing we can also see, and OCT also show us, and angiography already, fluorescein angiography already showed us, is the persistence of vascularity in front of the fovea. So that's also a hallmark in the fovea of the premature babies. That can also be seen in OCTA. So the most superficial vascular layer is not developed, but the most deep vascular layers, so the deep vascular layers, is within a vascular retina. You also can have some subclinical signs. What do I say? You can find in most of the babies, I mean, sometimes in some series, more than 60% of some kind of edema of the macula. Some people say it's edema, others say that's schisis. What this means, when you perform a fluorescein angiography, you don't see any kind of leakage in those edemas that you see in OCT, and also you can see here, it seems like almost like schisis. And also when you see with indirect ophthalmoscope, you don't see anything. So this is a subclinical sign in the OCT of something that is happening and that you cannot see. It can be that eye that is stretching so much that the retina is contracted by the vitreous, or it can be some kind of sign of some kind of inflammation, because most of the eyes there is a connection between the presence of this sign in the OCT and the development of ROP, of type 1 ROP. Also, OCT can show you how the development of the different layers happens between the treatment of laser and the treatment with anti-VEGF. It's very interesting that the anti-VEGF treatment almost seems that you have a more rapid inner and outer layer development. It's like if the photoreceptors compact more easily after the anti-VEGF treatment than with the laser treatment. And finally, we can see and guide and objectively observe what's happening in the acute phases in the periphery, so in the area where the transition is, where you have the ROP. And you can see perfectly the neovessels, the flat neovessels, the traction, the schisis traction before you have the retinal detachment. So you can see all the details of the different stages objectively seen in the OCT. And OCT now is used to classify you the stage, to tell you the stage objectively, and to tell you the area. So you can know if it's in zone 1, zone 2, or zone 3, and you can make absolutely objective count of the area of not only the area where the ROP is, but the extension of the ROP. So with, again, the artificial intelligence, we can objectively measure and compare all the stages and decide which we have to perform the treatment or not. So objectively, OCT is trying to be used in this kind of algorithm to decide if you have to treat or not treat these eyes. Of course, you have to have this machine, and this machine is quite expensive from my knowledge. Also, as we saw in the angiography, fluorescent angiography, you see this point in the initial times of the choroidal time, and you can see also that in OCT you have a less thick angiography, a less thick choroid than you have in the normal babies. So those two machines can help you. Sorry, just take home a message from this one. So those two exams can help you understand not only physiopathology, but help you in a more objective way how to decide the eyes that need treatment and when do you need to have this treatment. Of course, again, we know clinically how to do it, but sometimes we have doubts, and sometimes we call the colleague, what should I do? Is it really stage 3? Is it really stage 2? Objectively, in the future, with these two machines, we can objectively make the decision. So that's a long way. So until now, we don't have still this algorithm. But when the man begins to think something, I believe that soon we'll have this kind of algorithms. But at the end, I think that our eye will decide really what to do with our patients. Well, that's my message. Any doubt? And okay.